Hello, good evening, everyone, and welcome to the Eurogen webinar programme. Just before we get started, I'm going to take a couple of minutes to explain a little bit about what Eurogen is and does. Eurogen is one of the 24 European reference networks created in 2017 by the European Commission, and they all deal with patients with rare diseases and complex conditions. And in our case, it's rare urorectogenital diseases and complex conditions. So really where the expertise is rare. And we're primarily a surgical ERN. And we're currently 56 healthcare providers in 20 member states. And we aim to work together to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. Now, some of our activities, I have been saying for the last couple of weeks that we have a new upgraded clinical patient management system. IBM have been working really hard with the European Commission, and we've now got a beautiful new system which enables us to do cross-border virtual consultations. So please don't be shy. If any of you have a tricky case, please contact us via the website, and I'm assured that in about half an hour we can give you access to a fully secure system. You can upload the patient medical information and we can contact the clinicians, probably in high volume centres, that can get on a virtual case discussion with you and give you their insights and share their experience. So please don't hesitate to get in touch. We'd love to test our new system. We also do training and education activities, write clinical guidelines together, and of course, we have written this fabulous book on rare and complex urology. So I do recommend that you buy it. So our topic this evening, it's one of our colorectal webinar series with ERN Ernica, and it's about motility of the rectum in anorectal malformations. So it's going to delve into the role of anorectal manometry in the diagnosis, management, and function and organic defecation disorders, with particular emphasis on congenital colorectal conditions. And our speakers this evening are Professor Mark Benninger, who is a paediatrician at the University Medical Center in Amsterdam in the Netherlands. And we also have, it's a privilege to have Professor Sebastian King, who's got up very early to be here with us this evening in Europe, and he's paediatric surgeon at the Royal Children's Hospital in Melbourne, Australia. This is also supported by ARMNet and also EUPSA. And the webinar is eligible for EACB certification points if you fill in the survey within 2 weeks of attending the live webinar. So thank you very much for being here. And Sebastian, I'm delighted to give you the floor. Over to you.
So good evening, everybody. I hope you can hear me. Special welcome as well to Sebastian, who joins us very early in the morning. I will discuss with you today the role of anorectal manometry, not only in organic defecation disorders, but also in functional defecation disorders. And I will show you how difficult it is to perform the anorectal manometry, to analyze the manometry, and I will, of course, discuss the anatomy where we are measuring the function of the anal rectum. So how do we use anal rectal manometry? It's a physiological test which assesses the resting and squeezing sphincter tone. It evaluates the rectal anal reflexes. Sometimes it's very valuable to look for the rectal sensation, and of course, more importantly as well, in the last 20 years, is the pressure changes during attempted defecation. But first, we have to discuss a little bit the anatomy about the internal anal sphincter, which is under autonomic control and primarily responsible, as you know, for the resting tone. It's almost always contracted, It relaxes in response to certain stimulation, and it relaxes only for a short interval. Then, of course, which is also very important in performing anal rectal manometry, is of course the external anal sphincter, which it is under a voluntary control. It's also responsible for part of the resting tone, and of course we are able to increase the pressure by squeezing and lower during defecation or straining without defecating. And there is a reflex contraction when intra-abdominal pressure suddenly rises, especially during sneezing or coughing. And then another important muscle involved in anal rectal function is the puborectalis muscle. It's also under voluntary control, but also mostly in involuntary control. And it contributes to the resting tone. And by contracting, it creates a sharp angle around 90 degrees between the rectum and the anal canal, which, as you know, helps prevent involuntary leakage of stool. And when relaxed, for example, during defecation, it straightens the anal rectal angle, allowing for passage of stool. So the internal external sphincter, the external anal sphincter, and the puborectalis muscle are very important when measuring anal rectal manometry. There are many different anal manometry equipments, and this is just to show you a water perfused catheter and a solid state catheter. And this is also a problem because different catheters measure different things during our investigations. So this highlights the difference between a high resolution anal rectal manometry and 3D HR anal rectal manometry catheter with the conventional catheter as I used many years ago. So the most important thing is many more sensors. There are color plots where we were using line plots, and the preparation is far more easy now if you compare it to what we do. An important thing is, as we have to appreciate, are the costs. The costs are very high, and at the same time, the catheter durability is only limited. This is what they look like, the different catheters, and especially we have to concentrate on the diameter of the catheter, which I show you later, plays a role when measuring anal rectal function. The costs are here. These are catheters we used. A 3D catheter, approximately $26,000 with those balloons, and the normal high resolution catheter is half of the price, but still very expensive to use. These are the plots we see during high resolution manometry. The catheter is, you can see here, and surrounded by the sphincter complex. And here you see a decrease in sphincter pressure, showing by a difference in color. The more light the color is, there is a relaxation, and the more the sphincter is contracted, like here, the color is red. And these are the new manometry patterns we see using 3D manometry. And as you can appreciate, I come back later to it. This is the conventional manometry, this is the 3D, and this is the later 3D high resolution manometry. Why do people use it these days? Because you get another insight of the sphincter complex. For instance, in those people in those the relation during defecation, you can now appreciate the impressions which are made by the external anal sphincter compared to the impressions made by the puborectalis. And in the old days, this was not possible to measure these different muscles. Okay, if we compare the two measurements, these studies were performed in Columbus, Ohio, in the United States. As you can see, these procedures were performed awake, and very significantly, the pressure in the 3D anal rectal manometry, if you use these kind of catheters, was significantly higher compared to the conventional, so-called conventional high-resolution anal rectal manometry. Moreover, if you ask the parents, the children using these catheter, which are are larger than the other catheter is more unpleasant and more painful. So we concluded about this paper, the use of the 3D anal rectal manometry catheter may cause more discomfort without providing more useful information in children without anal rectal malformation. So we do not suggest to use these kind of catheters in children with without known anatomical abnormalities. So the size of the catheter makes a difference for the pressure you measure in the anal canal. There are several protocols used in the literature. This is the American protocol used to perform anal rectal manometry. This is a protocol used by the British Society for gastroenterology, and this is a paper we produced with Esbjørn, also with our old suggestion. And this makes it sometimes difficult because the protocols are not always similar, and therefore we get not always the same results using different protocols. When we use it, we try to calm the patient, be careful. We communicate with the patient, and we have a certain plan to fulfill the protocol. And these are, you can have the slides afterwards, of course. This is the steps taken during the manometry measurements, and is the accommodation of the catheter, the resting pressure, squeeze pressure. If necessary, look at endurance squeeze, the bear down maneuver, which is very important. I'm not that much interested in the cuff reflex, but some people use it. And of course, for many diseases, it's very important to look for the rectal anal inhibitory reflex. And sensory testing, inflation of the balloon, is sometimes tricky because especially in younger children, they don't exactly know what you're asking for. And in my experience, many children already say they feel sensation despite the fact that the balloon is not inflated yet. So this is a tricky part of the anal rectal manometry. These are the different patterns which can show. This is, for instance, a cuff reflex. As you can see, a rise in sphincter pressure. This is an endurance squeeze pressure, where you can see that you ask the child to squeeze on the catheter for a longer period. So these are the different patterns, and this is very frequently used to show the rectal anal inhibitory reflex. Here is the inflation with air of the balloon, and here you see a relaxation of the sphincter, which is highlighted by a decrease in pressure, which has a blue color. So this is what it looks like in using the conventional anal rectal manometry, influx of air, and you see a slightly decrease of pressure, which is the rectal inhibitory reflex. Very importantly, this is shown by this, and as you can appreciate, the more volume you put into the balloon, the longer duration and the deeper the reflex you will see on your screen. Okay, this is what lastly, what I will explain is the bear down maneuver. Also very importantly, because we and surgeons are always looking if children contract rather than relax their sphincter complex during defecation. And this is the conventional manometry. Here you see a normal defecation with a rise in abdominal pressure, and at the same time you see a relaxation of the sphincter complex, whereas here's an abnormal defecation with indeed a rise in abdominal pressure, but at the same time a contraction of the sphincter complex. And then this now looks like this in the color plots. Satish Rao from the United States, an adult gastroenterologist, suggested to use different types of dyssynergia. We don't use it that often, but if you like to use it, then you have to discriminate between an adequate rectal push with a paradoxal contraction of the sphincter complex. Here you can see an inadequate rectal push effort with, again, abnormal contraction of the sphincter complex. Type 3 is an adequate rectal push, but nothing happens in the sphincter complex, not contraction, but also not relaxation. And finally, there is an inadequate push with inadequate relaxation. Again, we in the Netherlands hardly use these types of dyssynergia, but they are published in the literature. And again, I show you the new examples of using 3D high-resolution anal rectal manometry, where you can discriminate the external anal sphincter with the puborectalis sphincter to show if there are defects in either sphincter during defecation, which is completely new and described by Adil Barucha from the United States. So what are the indications? You probably all know them. To diagnose internal anal sphincter dysfunction due to suspected anatomical or organic disease in a child with refractory constipation, but also what we're looking for today is anal achalasia. To diagnose pelvic floor dyssynergia in children with constipation. And then always the question is, if you diagnose this, is this a candidate for biofeedback or pelvic floor physiotherapy? I have a different opinion about this than many gastroenterologists and probably pediatric surgeons in the world, because I will show you some data on biofeedback and pelvic floor dyssynergia. What we also like to do, but there are hardly any data to evaluate the effect of anal sphincter directed therapies like Botox in children with, again, refractory constipation or anal achalasia. But I also know that many surgeons use botulinum toxin in those children with anal rectal malformations or Hirschsprung's disease when they still have constipation. In a smaller category, you can evaluate patients with retentive or non-retentive fecal incontinence due to suspected anatomical or organic disease. And finally, to evaluate post-operative patients with Hirschsprung or anal rectal malformation. So this slide summarizes when you can use anal rectal manometry. Then, very importantly, do you perform the manometry awake or under sedation? Because it makes a huge difference. Under sedation, of course, you can only measure resting pressure and the existence of the rectal anal inhibitory reflex. While during awake, you can ask the child to exactly do what you're asking for, like squeezing or coughing or pushing during defecation. So this makes a huge difference. And not only that, but we have to keep in mind that many sedation medications we use have an influence on the rectal anal inhibitory reflex, but also sometimes on sphincter pressure. I have no time to go into this, but we did a study together with the United States in children awake versus under general anesthesia. Most of them were using propofol. And as you can appreciate, the rectal anal inhibitory reflex identified both while awake and under general anesthesia was in 50% in this population, where only under general anesthesia there were significantly less children showing a normal rectal anal inhibitory reflex. So we suggested that during if the rectal anal inhibitory reflex is not visualized during anal rectal manometry while awake, a repeat anal rectal manometry under general anesthesia might be indicated. So again, please look at the difference in canal pressure during awake and under general anesthesia, and look at the sedation you use, because it can have influence on sphincter pressure. So now we go back to when I was younger, when I studied children with constipation. And at that time, we did a large randomized control trial comparing conventional treatment using toilet training and intensive laxative treatment with conventional treatment and in addition biofeedback. And this was because many of the children had an abnormal defecation pattern. And as I showed you, had dyssynergia in more than half of the children. And please look at these data, these percentages, because they come back in the other studies in Hirschsprung's disease, but also in anal rectal malformations. And indeed, we were able to show that if you use biofeedback in these patients, a significant percentage of children was able to relax their sphincter complex during defecation, whereas those children who were not treated with biofeedback were not able to change this response. However, if you look at outcome of the study, it didn't make any difference. So these are the results of children who were effectively treated with either conventional treatment or with, in addition, biofeedback. So despite the fact that we were able to change the abnormal defecation with biofeedback, it had no any influence on the results at 6 months, 1 year, and 1.5 years. So I thought, when children are more and more capable in understanding what the computer will show you, we thought that only the manometry which was performed at the beginning of this biofeedback study influenced these children. So we did another very large study, including 200 children again, where we were really interested in what the effect of anorectal manometry by itself had on outcome. And these are the data we have. We have the same normal defecation dynamics as in our first study, although it's a little later. And the other anorectal manometry parameters were completely normal. And again, we didn't see any difference in success rate with respect to defecation, fecal incontinence frequency, or laxative use. Approximately 60% of this large patient group was treated successfully, despite the fact that they had only 2 manometries in this session. So I think that despite the fact that children have abnormal defecation in a huge percentage of children, changing this pattern is not related to outcome. Okay. Others have also looked at the evaluation of fecal incontinence in children with functional constipation using anorectal manometry and colonic manometry. 280 patients were included. All patients underwent colonic manometry, and most of them used solid state to look for anorectal function. And there was no difference, but Sebastian will probably go into this in colonic manometry parameters. If you look at the anorectal manometry, an overall abnormal parameter with regards to anorectal manometry was found in 29% of the children. Although the median resting pressure was higher in those with constipation without fecal incontinence, it was both fell in the normal range compared to healthy children. And this was also true for the rectal anal inhibitory reflex. Most children showed a normal rectal inhibitory reflex, only inflating less than 60 mils, whereas a small percentage had the rectal anal inhibitory reflex elicited with higher amounts of air, which probably mimics a megarectum. The median volume of first sensation was in both groups exactly the same, and abnormal defecation maneuvers was significantly lower if you compared it to our studies we did 20 years earlier, because only 25 to 30% of the children showed contraction during defecation. So this also shows that it's so important to have the same protocols. So the conclusion of this particular paper showed that there's a lower median anal pressure compared to those without fecal incontinence, although it was always in the normal range. And there was no other anorectal manometry parameter which could differentiate between those children who have having fecal incontinence. And there was also no association between therapy response and any anorectal parameter. So these these authors concluded that anorectal manometry does not seem to be of benefit in the evaluation and to guide management in children with functional constipation and fecal incontinence. Very important conclusion. Finally, this is also a recent study using even more sophisticated catheters, and I show you this particular study because it mimics manometry in children with mild anorectal malformation. This was a study performed in 29 children, children again with and without fecal incontinence. And as you can see, the maximum pressure and the resting pressure is higher compared those to the numbers I showed you with the normal high resolution manometry catheter, but also with the conventional manometry catheter which we used a long time ago. Also, I already showed you this, but I want to particularly focus on the findings with respect to the resting pressure in the anterior-posterior position, both during maximum resting pressure and mean resting pressure. And please keep this in mind, because this will come back in the studies I will show you later. The lower pressure was found in those with fecal incontinence. The authors couldn't exactly stress where this what this finding is based on, and I also am not able to particularly understand the meaning of this finding. But again, it was shown that in fecal incontinence the resting pressure was a little lower. It might be caused by the defect found in this using this particular catheter. So now going over to the anal rectal malformations, shortly on Hirschsprung's disease. This is the patterns we can see during using these kind of catheters. Again, a normal relaxation, as you can appreciate here. And here, after inflating the balloon, there's no decrease in pressure, showing an absence of the rectal anal inhibitory reflex. Using these kind of catheters to show the absence of the rectal anal inhibitory reflex is very sensitive, as I can show you here, especially in very young children. But they also concluded that it has a reduced efficacy in older children, likely due to complications from chronic constipation. And it might be the case that higher volumes are needed to elicit this particular reflex. Okay, very old study again from the past, which shows that rectal suction biopsy is the gold standard to exclude Hirschsprung's disease compared to contrast enema and anal rectal manometry. So in our hospital as well, we in almost all cases where children are suspected of Hirschsprung disease, we will first go to a rectal suction biopsy and not use anal rectal manometry. Okay. Then Sebastian King did some great studies, including this systematic review, where he looked at the post-operative anal rectal manometry in children with Hirschsprung's disease. And 23 studies satisfied their inclusion criteria, and post-operative anal rectal manometry results were reported in 682 children. However, they were very disappointed with the results because they demonstrated a lack of high-quality evidence underlying the current understanding of post-operative anal rectal manometry in these children. And as I showed you before, and this is because so many different protocols are used, there was little consistency in reporting the manometry outcomes between the studies. And they concluded, based on all these data they looked at, that the emphasis must be placed on the application of standardized manometry protocols, but also cohort reporting and patient outcome assessment. Very important study, which shows that we have to do a lot of work, and it also shows and stresses the collaboration between gastroenterologists and pediatric surgeons. So the last part of the study of my presentation will, of course, deal with anal rectal malformations. And I like this study very much. I found it in Children, was published last year. And why do I like it? Because colorectal surgeons included all kind of different entities where they used anal rectal manometry. Children with constipation, with fecal soiling, rectal prolapse, anal rectal malformations, Hirschsprung's disease, and more rare cases of rectal abnormalities. Very importantly to know is that if we look at the anal rectal manometry, anal rectal malformations, they have a significantly lower pressure compared to those with the constipation or fecal incontinence without an anal rectal malformation. But again, if you can remember, these pressures are also lower than showed in former papers. Also, importantly, they were not able, or they were only able in, for instance, the anal rectal malformation, to only see in a small percentage of children a rectal anal inhibitory reflex. And I will show you in the papers which I will discuss after this paper, that many more children do have, in the opinion of those authors, an rectal anal inhibitory reflex. Again, not surprisingly, if the resting pressure is low, the maximum anal squeeze pressure is higher if you compare those children without anal rectal malformations with those with anal rectal malformations. Finally, I was surprised by the high percentage of dyssynergia in all these different anatomical abnormalities. And it's difficult for me to understand why it is that children with constipation or Hirschsprung's disease or a spinal anomaly or an anal trauma have such a high number of children with dyssynergia. Okay, then this very important paper was published only 2 years ago by the group of Paul Bruns, and they looked for diagnosing mild forms of anal rectal malformation with anal rectal manometry. The strength of the study was that it was a prospective trial, and they looked for the mild anal rectal malformations by examining the perineum combined with their golden standard electrical stimulation of the anal sphincter under anesthesia. But they also performed 3D high-resolution manometry to assess its value for diagnosing these forms of CAM. They included 66 patients. They were all very young, and they presented with constipation and were suspected of these congenital anal rectal malformations, idiopathic constipation, or Hirschsprung's disease. This was the schedule. So the children came in, they were constipated. Then based on medical history and physical examination, they were able to differentiate between those children suggested for only constipation, whereas based on medical history and physical examination, children were diagnosed with an anal rectal malformation. And then they performed 3D high-resolution anal rectal manometry, and finally they confirmed their data with electrical stimulation. And these were the patterns they were shown. On the left side, you will see sphincter relaxation, and here you see sphincter contraction in different disorders. This is Hirschsprung's disease, anal rectal malformation, and idiopathic constipation. And the major finding they did in those children with anal rectal malformation was an abnormality in the anterior part of the sphincter. So they were able to show that these children had these particular abnormalities in contrast to children with Hirschsprung's disease or idiopathic constipation. And as you can remember, similar findings were done in another study by the Italians, also showing abnormalities in this position of the sphincter. So they showed that patients with rectoperineal abnormalities revealed a pressure gap along the anterior part of the anal sphincter, high specificity and sensitivity, far more higher than other studies. And they showed that all these patients had a high sphincter pressure and they were not significant. And that is to my, hopefully Paul Bruns is in the audience, and he might explain why there is no difference in pressure while having found this abnormality. But very interesting data. Then another study by Paul Bruns' group showing investigating the relation between the interanal sphincter and defecation disorders in patients with anal rectal malformations. They included a bunch of different anatomical abnormalities, the defined constipation by the Rome 4 criteria, but also by the Maastricht definition for constipation, which uses the balloon retention test and the solid stool incontinence, which was objectified when the patient could not hold the rectal balloon. And again, their findings are striking and a little different than the people who were presented by the colorectal surgeons in the United States, because they found the rectal anal inhibitory reflex in 67% of all the types of anal rectal malformations. All patients, and they had very nice findings, because all findings patients who had not been operated on and those who had undergone less extensive surgery possessed the anal inhibitory reflex. So they suggested that it's related to operation. And in contrast, patients who underwent posterior sagittal anal rectal plasty possessed only in 44% of the children the rectal anal inhibitory reflex. They didn't find any differences in sensation, and over time, patients without a rectal anal inhibitory reflex seem to develop significantly higher rectal volumes than patients with rectal anal inhibitory reflex. Also, surprising to me is that they found no difference between the reflex and fecal incontinence. And they also found that absence of the reflex, the resting anal pressure, and fecal incontinence were related, which is a more common finding. Okay, so these papers show very nice findings in children with anal rectal malformations, although the group of children included in the latter study is very different. Okay, finally, I will discuss a paper by the group. I think they are from Denmark, where they showed a correlation of anal rectal manometry to severe fecal incontinence with anal rectal malformations. And again, different abnormalities found and different surgical approaches to treat these children. However, if we look at these children, and they differentiated children with a sphincter defect and no sphincter defect using, again, 3D and manometry catheters, then there was no significant difference in the children with and without a sphincter defect. And again, the resting anal pressure in their population is significantly lower than found by Paul Bruns. So again, they probably used different catheters with a different size, and they used probably a different protocol, which makes it so difficult to make a firm conclusion. Those children with no sphincter defect had lower Wexner score compared to those with a sphincter defect. They also looked at dyssynergia in these patients, again, with different children included in the study with different repair and different differences in functional outcome. They also used transit time, which is, I think, it's very good to compare not only function, but also look at transit. And to my surprise, there was, in those children with dyssynergia, had no significant increase in transit time, whereas in children with constipation, this is almost always the case. If they look at manometry patterns, then they concluded that all patients fulfilling the Rome 4 criteria for constipation had dyssynergia, which is very high, and 69 of these patients had a colonic transit time within the normal range, which is also in contrast to studies in children with functional constipation. Dyssynergia was also observed in patients without signs of constipation, which is a well-known finding. And dyssynergia due to isolated contraction of the puborectalis. As I showed you in one of the first slides, they are now able to discriminate between contraction of the external anal sphincter, and puborectalis was found in also a majority of their constipated children. The dyssynergia during attempted defecation in anal rectal malformation patients is disregarded the presence of constipation, and they found that the majority of patients had an isolated contraction of the puborectalis, which is completely new for me, and I have no clue if you can treat this isolated contraction with, for instance, biofeedback. Again, no difference in neither total or segmental colonic transit time. To me, surprising, because those children who withhold their stools should have an increase in the latter segment of the colon. Finally, the last two slides. This very nice systematic review by Sebastian King again is very disappointing, to my opinion, to read. They assessed 63 studies, and their overall finding was not a lack, but a complete lack of consistency between the manometry protocols, the analysis of data, and the interpretation of finding, as I showed you in the different papers I discussed. And this echoes conclusion of a similar review of anal rectal manometry performed in adult populations. So despite studies identifying abnormalities in anal rectal function, definitions of normal were rarely provided or vaguely described, which made interpretation very difficult and comparison even impossible. So at the end of the day, they suggest how to go forward by using the demographics, medical characteristics, and look for bowel function. So in conclusion, the most common accepted indication for anal rectal manometry in children is the evaluation of the internal sphincter relaxation in response to rectal balloon distension to help exclude Hirschsprung's disease. But I also mentioned that we in our center prefer a rectal biopsy, which in my opinion is still the golden standard. Disappointingly, but many studies have now shown anal rectal manometry has no benefit in evaluation and guiding management in children with constipation, with or without fecal incontinence. And Sebastian also showed in his systematic review that there is a lack of high quality evidence underlying current understanding of post-operative anal rectal motility in children with Hirschsprung's disease. Paul Broen showed that in a particular smaller population, a specific pressure gap along the anterior part exists, which might be helpful in understanding anal rectal function. What are the future directions, to my opinion? Well, anal rectal function, as you all know, impacts continence, but defecation regulation is far more multifactorial. Bowel dysfunction after anal rectal malformation repair requires considering manometry findings in a far broader context, and future research should focus on standardizing anal rectal manometry techniques and understanding of anal rectal function to develop reporting guidelines for cohort characteristics and clinical outcomes in anal rectal manometry patients is, to my opinion, essential. Of course, I also showed you that these new techniques offer insight, but manometry should be interpreted in the broader context of continence mechanisms to improve understanding of long-term bowel function. And with this, I give back to you the floor to Sebastian King.
Well, thank you very much for the opportunity and the invitation to present today, this evening, this morning, wherever you are. I'm Sebastian King from the Royal Children's Hospital in Melbourne, and it's a great honour to be presenting to the European Research and Network and the Reference Network. So you might be asking, why am I presenting from Melbourne? And as Mark has shown through his presentation, we've been working in motility in congenital colorectal conditions for many years now, but I just wanted to give you a little bit of a background about Melbourne and why the Royal Children's Hospital has had such a role in the understanding and the management of these conditions before we talk a little bit about the role of colonic motility assessments and how they've improved and what the future might look for these assessments. So here is Melbourne, Australia, second largest city in Australia, and you can see the Royal Children's Hospital down there on the right-hand side, right next to the city. Great place to work, wonderful opportunity to work there. Melbourne looks a bit more like this at the moment because it's currently about 4:45 in the morning. But that's one of the downsides of living in Australia is joining these meetings at various odd hours of the day, but it's always a pleasure to be able to join our European colleagues. So the history of colorectal conditions at RCH is really quite important as a pediatric surgeon, because there have been 5 or 6 absolute superstars in our field over the last 50, 60 years. And it's you really are standing on the shoulders of giants when you work in our department, and it's a great privilege and pleasure to have actually worked with and collaborated with a number of these surgeons over the years. So the first 2 surgeons that I wanted to highlight were Douglas Stevens and Durham Smith. Douglas Stevens died in 2011. Durham Smith died very recently at the age of 103. But these are 2 titans in our field and wrote the first real textbook on the anorectal malformations in children. Douglas was based for many years in the UK at Great Ormond Street, and then eventually at Northwestern in Chicago. But in between those two, he was in Australia as the Professor of Paediatric Surgery in Melbourne, and as a really dedicated embryologist. And now understanding of anorectal malformations, and particularly some of the things that Mark has just highlighted, the puborectalis, for example, come from his incredible work at the 50s, 60s, and 70s. So they worked together and wrote, as I said, this first textbook. And their work was then carried on by these two surgeons. So Helen Noblett, the bottom left there, who had a profound impact on the management of Hirschsprung's disease. As you can see her there with the suction rectal biopsy gun that she developed in the late 60s in Melbourne, along with Peter Campbell, the head of pathology at the time. And then next to her is Justin Kelly, who I had the great pleasure of being trained by many years ago. And Justin, more known as a paediatric urologist, particularly in the work of bladder exstrophy with the Kelly procedure used all over the world now. But these four surgeons had a real impact on the understanding of both anorectal malformations and Hirschsprung's disease. And then many of you will recognize this young surgeon here on the right, which is Alberto Pena. And as it turns out, the reason why Alberto Pena really got interested in colorectal conditions was that he was a trainee with Justin Kelly in the late 60s in Boston under Professor Gross. And that same textbook that Durham Smith and Douglas Stevens had written, Justin Kelly had taken to the States. And I've actually seen Alberto's annotated version of that book where most of it's crossed out as he disagreed with many of the thoughts that Durham and Douglas had. And that really led to the early papers in the 1980s around the understanding of a new surgical approach to an anorectal malformation, which is the posterior sagittal anorectoplasty, which we all now use and have been using for the last 40 years. So based on that, the first real classification for anorectal malformations was the wing spread classification. You can see there the two main authors, again, Douglas Stevens and Durham Smith from the early 80s. And this was the first real sort of attempt to try to determine the different types of malformations and how the surgical approach to these malformations should vary. And so these were the setting of high, intermediate, and low malformations. And that was really used for the next 20 years until this man, who some of you will know, which is Professor John Hudson, who was my PhD supervisor, who's mostly known for his urological work in testicular descent and congenital adrenal hyperplasia, but was actually a real forward thinker in his understanding of motility. And that's where I started to enter this space of colonic motility. And towards the end of my PhD time, he actually wrote or co-authored and edited this book on anorectal malformations in children. And this is the photo of all of the surgeons that came together to write and rewrite into the new Krickenbeck classification, which we've now used for the last 20 years, which is a more clinically based approach to the understanding of anorectal malformations and moving away from the high, intermediate, and low, and more into the sort of more common versus less common forms of anorectal malformations. I had the great pleasure 6-7 years ago now of hosting Mark Levitt at the Children's Hospital here in Melbourne. And you can see Mark, who's really the best known paediatric colorectal surgeon currently, has taken on the mantle from Alberto, having trained with Alberto Pena for many years and worked with him. But Mark was here in Melbourne at the Children's Hospital, and for him, he really loved being able to spend time with John Hudson, and particularly Justin, knowing that strong connection to Justin and his mentor Alberto. And some of you on the call tonight or this morning might also recognise this wonderful surgeon at the bottom right here, Eva Lurie, originally from Nantes and then Necker in Paris, who again continued that work with us in the Children's Hospital around the understanding of anorectal malformations. So I now want to focus on, and hopefully that will give you an understanding of why my interest in these conditions, but also why Melbourne has had such an impact and the Royal Children's Hospital has had such an impact internationally on the understanding of congenital colorectal conditions. And I'm now going to focus on anorectal malformations and Hirschsprung's disease. So you've heard lots now from Mark around the understanding of anorectal malformations. And for those who don't know so much about this, that there are a whole collection of these types of conditions that are lumped within the one grouping of ARMs. It gets confusing because ARM can also be anorectal manometry, but for as a pediatric surgeon, ARM is definitely an anorectal malformation. But you'll see here on the left-hand side the rectovestibular fistula and the short common channel of the cloaca. They're two of the more common versions of an anorectal malformation in a girl. And you can see there where rather than having the normal anal opening, you will have the rectum, which is poorly formed, pulled forward into the vestibule in the form of the rectovestibular fistula. So behind the vagina, the rectovaginal fistula is a rare variant, but the rectovestibular is probably the most common, along with the perineal fistula. And then if you look at the more complicated form of cloaca in girls, of anorectal malformation in girls, which is the cloaca, the more common version of that is the short common channel. And for those that don't know that much about cloacas, it's where all three of the structures in the girl coalesce into one. So the urethra, the vagina, and the rectum coalescing into one with a single opening onto the perineum. And as you could understand, this is a lifelong condition, both in the rectovestibular fistula and in the cloaca. If you then look at the boys, one of the more common types is the rectobulbar fistula. So again, here the rectum, rather than entering and opening out onto the perineum, is opening into the bulbar component of the urethra. There are also prostatic versions, there are bladder neck versions, and then there's another version there, which is the anorectal malformation with no fistula, which is almost always seen both in boys and girls in the syndromic setting of Down syndrome. So you can see that there are many variants of anorectal malformations. And I suppose the most important thing is the understanding that in the past, many of these conditions were felt to be fixed by their surgical repair in the first year of life. But our understanding has very much shifted in the last decade or two to a real clear understanding that these are lifelong conditions, and that many, many children and adolescents and adults with anorectal malformations struggle with both bowel and bladder continence. And this is it's a study that my colleagues in Nationwide Children's Hospital in Columbus and myself with our team here in Melbourne published recently in the Annals of Surgery. And this is the largest study of its kind looking at anorectal malformation and patient-reported outcomes. And what we demonstrated here was that we had over 900 patients involved, which, as you can appreciate, for a pediatric surgical study, we worked hard to be able to bring those data together. But it showed very clearly that continence continued to be a major issue for these children from a bowel perspective. So over 80% of children at the age of 5 were incontinent. That moved to about 70% between the ages of 6 and 12. And then 80% of children were continent by the time they got over the age of 12. But you're still talking about 20% of children with anorectal malformations being incontinent over the age of 12. And we know that the long-term impacts of incontinence for children and adolescents moving into adulthood is profound. This is our study here has been very kindly already commented upon by Mark. And this is the work that I need to highlight of Hannah Evans-Barnes, who was one of our PhD students who's recently just graduated from her PhD and did some fantastic work and started her PhD work with us just as COVID was happening in 2020 into 21. And so we needed to pivot due to lockdowns, particularly in Melbourne, and the inability to get patients in to some systematic reviews. And so she spent a large part of the first year or two of her PhD study working on these systematic reviews. And for that, I'm very grateful. And I think that we as the international sort of surgical and pediatric community can be very grateful for the work that she put into demonstrating the quality, or therefore lack of quality, of studies that are in the realm of pediatric manometry for these conditions. So as Mark alluded to, This study showed there were 63 studies, there were 1,755 children included, but there was a clear lack of standardization. Very few studies actually demonstrated patient characteristics, and there was significant variability in how the manometry equipment was described, how the protocols were described, and how these were interpreted. And you saw this slide previously, so I won't spend time with it, but it was we outlined what we thought were the clear aspects that needed to be demonstrated in each of the studies moving forward in the understanding of anorectal manometry for anorectal malformations. Hannah also looked at the postoperative colonic manometry in children, and that's the focus of most of the work that I'm going to do today. So the postoperative colonic manometry in children with ARMs, again, systematic review, and you go from having 63 studies of anorectal malformation, anorectal manometry, to 4 studies of colonic manometry in anorectal malformations. You go from 1,755 children to 35 children. So as you'd expect, insufficient reporting of medical characteristics, poor understanding of bowel function and manometric outcomes, and interestingly, no high-resolution colonic manometry studies reviewed in these patients. So I'm now going to move to Hirschsprung's disease. And as Mark said, Hirschsprung's disease, named after our Danish colleague, Harold Hirschsprung, is actually a pediatrician. We did a huge amount of work for pediatric surgery, including the description of pyloric stenosis. But for those, again, to get you up to speed, for those who aren't used to looking after patients with Hirschsprung's disease, the majority of children will have short segment Hirschsprung's disease, where the rectum and the sigmoid colon have no ganglion cells, and the descending colon section proximal to that will be swollen above that relatively spastic contracted colon. You then have children who have longer segment disease. That usually represents about 10% of patients with Hirschsprung's disease, where you might have more involvement of the descending colon and transverse colon. And then you have a group who have total colonic Hirschsprung's disease, again, about 10% of patients, often seen more in the syndromic, more common in females, where the ganglion cells are completely absent from the colon. And you have, in those rare cases, actually, where you have small bowel involvement as well. Again, in the past, when I was training many years ago, this was sort of seen as being corrected by the pull-through procedure, the removal of the aganglionic bowel, the moving of the ganglionated bowel down to the rectum, down to the anus as a coloanal anastomosis. But we now realize that many of these patients with Hirschsprung's disease continue to struggle despite what is referred to as an adequate pull-through, so removal of the aganglionic and transitional zone. And so part of that work is, again, Hannah's work from her PhD, where we looked at patients and parents of children with Hirschsprung's disease beyond the early childhood, so age 4 to 14. And we demonstrate using various measures such as the family management measure, the parent experience of child disease, anxiety and depression scores, as well as PEDS-QL. And we demonstrated very clearly that these parents had really great long-term uncertainty and poorer ability to manage compared to their control cohort, higher rates of anxiety, higher rates of depression, and significant reductions in the proxy PEDS-QL scores. So these are conditions that previously were thought to be cured by the surgical approach and have been clearly demonstrated not to be so. So this is again, the work that Hannah did with looking at anorectal manometry in children with Hirschsprung's disease. There were a few more studies in this patient cohort, as you'd expect, because of the role of the rare that Mark has highlighted. 23 studies, 600 children. And again, the majority of the studies assessed had very poor quality. We looked at also the role of postoperative colonic manometry. And again, like the anorectal malformation cohort, few studies, only 5 studies, 184 children, very heterogeneous population, variable manometry protocols, and limited baseline clinical characteristics. So I'm now going to talk a little bit about colonic manometry, and Mark, did a tour de force on the different aspects of anorectal manometry. Many of the setups for equipment we use are similar. There are water perfused versus solid state. But when I did my PhD and focused on colonic manometry in slow transit constipation in children, these were the types of studies that I spent hours and days and weeks analysing, all by visual analysis, low resolution, few side channels, large space between those channels. We now look at what manometry looks like today, and this is work courtesy of colleague Phil Dinning, who's worked with me for many years, as well as Mark, demonstrating how much information is actually lost or missed by the use of low resolution manometry, and hence the need to move away from this. We also use a lot of color maps now and a lot of computer analysis that was not even present even 5 years ago. So I wanted to highlight some of the work that we've been doing in the colonic manometry Hirschsprung's disease space, because as a pediatric surgeon, I can do the same procedure on one child as I can do on the next and have a completely different outcome for that patient, the first patient compared to the second patient. And that intrigues me as to why is it this bowel in Hirschsprung's disease that is supposedly normal, as in ganglionated, is performing in a way that it remains either poorly ganglionated or aganglionic. So this is a study that we did as part of Hannah's PhD. We focused on colonic manometry with high resolution in Hirschsprung's disease. And I'm going to focus on just one particular component of the work that we did, which was the meal challenge. We looked at, so we placed these catheters, 24 side holes, 2 centimeter side hole difference into the cecum using colonoscopy. We then looked at a pre-prandial recording, and then we looked at a post-prandial recording. I'm not going to highlight our bicicotal responses today as I don't have time. So we focused on this pre and post-prandial recording, and we split the colon into a proximal and a distal component at the splenic flexure. So we analysed motility pre-meal and post-meal in 13 children, 12 males, which is not uncommon for the pediatric, for the Hirschsprung's cohort. Short segment in 9 of those 13, and we compared it with high-resolution colonic manometry from 13 young, healthy adult controls that was gathered by Phil Dinning. We looked at this timing of response, and as I said, we divided the colon into proximal and distal at the splenic flexure, and we looked at the pressure calculated in each of these regions in small 20-minute epochs, pre and post-meal, and then split those into 1-minute intervals further. And what you can see here, if we look at the first, at the top, the proximal colon, so this is up to the splenic flexure, and you can see there in the healthy controls are in blue, the Hirschsprung's disease is in orange, that prior to the meal, which is at time 0, so the 20 minutes before that the activity in the Hirschsprung's is comparable in the proximal colon to the healthy control. But following the meal, you see an immediate response in the proximal colon, not just in the distal colon, but in the proximal colon, which is a clear difference between that seen in the Hirschsprung's disease. You are not seeing the normal response to a meal, even in the proximal colon, the ganglionated section that has never had surgery on it. In these Hirschsprung's patients, you are seeing no real change in their activity in the proximal colon. Then look at section B in the distal colon. Again, you see little difference between the Hirschsprung's and the healthy controls in the pre-prandial component in the distal colon, but you see a profound difference, a doubling, and in some cases 2.5 times the activity in the healthy controls, whereas the Hirschsprung's disease, you have almost no change between the pre and post-prandial. So for those of us who spend all our time saying to children, with these conditions, to sit on the toilet post their meal, take advantage of the gastrocolic reflex, you can see in this cohort of Hirschsprung's disease that we're not doing well, that there is no real change in activity related to a meal. And you can see this in a different format. Again, the yellow line being the meal, and the proximal versus the distal. This is what the activity looks like in a control, whereas the Hirschsprung's patients do not demonstrate any pressure maps that are comparable to this. So how do we use that in practice? So I'm going to give you an example of one patient. Again, a child that I performed a Swenson procedure in, uncomplicated, our standard approach to short segment disease, where they were not doing well and how we used manometry to be able to influence what we did. So this is at the time that we were assessing him for manometry. He was 30 months old. He was known to have short segment Hirschsprung's disease. He'd had an uncomplicated lap-assisted Swenson procedure at 3 months of age. We do in theatre analysis frozen sections to confirm that we have brought through ganglionated bowel with a donut to make sure that it is circumferential. This boy had multiple presentations with Hirschsprung's associated enterocolitis. His X-ray there at 20 months shows dilated loops of bowel, as well as fluid-filled and stool-filled colon. We did a contrast study to confirm that there was no twist, which can happen when you're doing a Swenson procedure. And then as you can see there, he's got dilated colon all the way back to the cecum. This is a boy with short segment disease, but you can see why that bowel is not functioning appropriately. Whether or not you get that appearance because of enterocolitis, recurrent episodes, whether or not you get that appearance because of sphincter dysonergia, unknown. So we performed Botox at 21 months of age and repeated the rectal biopsy. Even though I knew that his initial pull-through was adequate, I needed to make sure. And on his repeat acetylcholinesterase stain, we were able to see that there was normal presence of nerve fibers and ganglia. So we repeated his Botox at 24 months, which was not particularly effective, and then at 27 months. And that's a little bit quicker than I would hope, but he had recurrent episodes of enterocolitis and recurrent presentations to hospital and admissions. So we performed colonic and anorectal manometry at 30 months of age. And I'll give you one snapshot, and you can see here, there is almost no activity. There was no response to meals. There was no response. There was no high amplitude propagating contractions seen. There were variable abnormalities in propagation and organization. And interestingly, there was almost no propagation beyond the splenic flexure. So even though this child had short segment disease and had ganglionated splenic flexure to coloanal anastomosis, he had almost no activity whatsoever related to meals nor a bisicoidal challenge. So we formed an ileostomy on this child. He's had no further episodes of enterocolitis since then. He's had significant improvement in dietary intake and growth as we've removed that section of bowel, often like we see in the IBD patients where they have a defunctioning ileostomy. And interestingly, no acute admissions to hospital since his ileostomy formation. He's now about 5.5. And we're getting close to performing colonic manometry on him as a way of determining whether or not he is ready for his closure. So I'm just going to now briefly touch on the next phase for us in terms of GI motility assessments. I'm aware that Mark and I have gone over time, so I wanted to be able to leave some time for questions. But this is work that we're about to, or in the process of doing with our colleague Greg O'Grady, who many of you might be aware of, adult colorectal surgeon who's now moved into the engineering and startup phase and started a company called Allometry, and who've really focused initially on gastric diagnostics, but are now moving into colonic diagnostics as well. So this is non-invasive GI motility assessments. This is a recent technical review in the Neurogastro Motility by Greg and his team, including Jan Tak, where they're looking at the concepts of body surface gastric mapping. So this is how we can standardize the methods. This is a technical group and clinical advisory group to look at how, using body surface mapping, we can overcome some of the technical limitations of electrogastrography for gastric, and now looking at this in the colon space and whether or not we're able to do this for colonic manometry. So we want to look at non-invasive colonic motility assessments. So body surface colonic mapping, or BSCM, it's going to be an ability to characterize motility disorders. It detects myoelectric activity through the abdominal wall. And this uses an 8x8 grid of electrodes in a flexible sheet that's able to be attached to the patient with an easy to apply non-invasive attachment process. So looking just like this. And we're about to start a process of mapping colonic motility in both patients with Hirschsprung's disease and with chronic constipation, functional constipation, and look at the objective measurements that we get with our colonic high resolution manometry, and map it to the BSCM to be able to see whether or not there's a potential for some patients where we would be able to not perform manometry on them and be able to move straight to BSCM, or use BSCM potentially as a screening tool for those patients that need to then go on and have the more invasive form of colonic manometry. These are ways of being able to sort of match them. And so there's been some early work looking at comparing BSCM and high resolution manometry. And if you look at section C there, we're being able to compare the manometry in the orange versus the body surface. And you can see in those patients that that you have a rise in activity following the meal and then a larger rise after the bicicotal, which is that last section. And the high amplitude propagating contractions are well picked up, both by the conventional high resolution colonic manometry, but also by the BSCM. So this is early work, but hopefully going to be able to look to replace some of the colonic motility that we do with manometry. I'll now leave that for question time. I hope that that's been useful and been able to give you some insights into why Melbourne has had an important role in the understanding of these conditions and how we continue to do our work down here in the Antipodes, particularly now with this body surface colonic mapping. Thank you very much.
Thank you very much, both of you. Thank you both very much for the elaborate presentations. So again, for the attendees as well as for you guys, the questions are in the questions field. So somewhere down below you have the Q&A with a question mark icon. If you click on that, you will be able to see the questions. I did see that a couple of questions came through during your talks. So if you could read them out loud, then everybody's able to know which question is being asked.
Mark, do you want to start at the beginning and work through those questions?
Well, yes, I will. Well, the first one is very nice comment, but no question. Does the type of defect in ARM and Hirschsprung's disease are different? Don't exactly understand what the question is, but if you look at the anatomy of all these kind of different diseases, my answer would be absolutely yes, but I don't know the exact meaning of the question. What you like to know? I don't know if you have comments on that.
I wonder then, Mark, whether or not I suppose there's such a significant difference between anorectal malformations and Hirschsprung's disease in terms of the anatomy, and as you can see, there's such a huge variety in the anatomy of anorectal malformations themselves. I think that's part of the reason why, Mark, some of a lot of the work that I've done over the last 10 years, I've deliberately tried to split Hirschsprung's disease and anorectal malformations, because as you know, for so long they were lumped together. And that's because they're rare conditions, 1 in 5,000. And so most centres don't have huge numbers of patients. We've got a great advantage here at the Children's that we're a large referral centre, so we have large numbers of patients. But I think that for many years, manometry studies and even functional outcome studies, quality of life studies, they lumped the two groups together. And so certainly when I started back here in Melbourne in 2015, I wanted to separate those. If we think about the types of the anatomy, the anorectal malformation patients essentially have poor external sphincter. And so part of the surgical repair for these patients is actually to stimulate where we think the external sphincter should be and place the neo-anus into that spot as carefully as we can. But they also have essentially no internal sphincter, because often we will need to remove the last centimetre or two of the rectum to form the neo-anus, because that area is atretic and abnormal and scarred up. Hirschsprung's disease is when we do our Hirschsprung's pull-through, they have an internal and an external sphincter. The external sphincter we work very hard not to impact on anyway, and very careful to not stretch the external sphincter. And it's one of the reasons why I don't do neonatal pull-throughs, because I feel that in a 1 or 2 week old, it's very easy to inadvertently destroy or damage the external sphincter. But nobody really understands what the internal sphincter is doing in Hirschsprung's disease. And it's fascinating, to bring these two things together, in that we have a number of children who have had, when we do our colonic manometry in Hirschsprung's disease, we always do anorectal manometry as well. To your point, Mark, we try to do as many as possible with them awake because we get so much more information. But in the younger patients, we might need to do them asleep. And for example, the patient that I just highlighted then had as a 2.5-year-old had an asleep anorectal manometry, and that child actually has a rare. So children with Hirschsprung's disease do not have a rare pre their pull through, but in a percentage of them, they are actually able to re-establish or establish a rare post their pull through. I don't have any understanding of how that happens. Nobody I know seems to be able to understand how that happens, but it happens. So something is going on there. There's a lot more that goes on there than we understand.
Essentially, the long answer on this very simple question shows how difficult it is. There is a difference in anatomy, there's a difference in operation style, and we still have all these papers trying to compare with each other, and this is too difficult. So therefore, I like your paper so much, and they suggest that we must far more collaborate with these kind of rare diseases, and this is probably the future direction to go to really understand what's going on. Okay, let's go next.
Speaking of papers, you mentioned a couple of times the papers from Paul Bruns. Well, he is actually in the audience and he has raised his hand. Shall I make him able to speak?
Yes, of course. Nice.
So I believe that he is able to unmute himself right now.
I did unmute myself, I hope. Yes?
Yes, yes.
Thank
Welcome.
you very much. Very nice presentation, Sebastian, Mark. Really very nice. Yeah, as you know, Mark, I'm busy already for many years to find out how does work continence. And what we showed next to the basal pressure and maximum squeeze pressure, that are voluntary effects. And what we found that there are autonomic reflexes who are helped to control the continence. And what we found that is really very important. A big part of the external sphincter is autonomically controlled by our body. And that helps us to be continent, and also the prerectal muscle. And we showed with healthy people, because we did go really very far in this, that we did try to make healthy people temporarily by local anesthesia in the surface of the anal channel. We could make them incontinent, although their basal pressure and the maximum squeeze pressure was perfect, but they were fecally incontinent. So I think it is very important that we understand much more, and that's what we are doing in our center, research about the different mechanisms. And I think indeed the autonomic continence reflexes are vital important to understand how continence works. And that is also a part of the function, what we see, that the Botox works, because Botox works on the external sphincter, on square-straighted muscles. And what we see that very often there is an overreaction of the anal continence reflex, and because of that you will become severely constipated. And if you inject then the botulinum toxin in the external sphincter, you see that the overreaction of the continence reflex goes down to normal level, and that these patients get much more better. Although you would not see that on the standard manometry with basal pressure and maximum squeeze pressure. So I think, but maybe it's an idea. I got already some mail of some colleagues. Maybe there is a place for a number 2 of this session, that I will make a session in the future to show some of these aspects what we found of the autonomic reflexes. Because I think it is it's a very promising direction to see, to understand more how it works. And that was also what you showed in detail. But we didn't understand why, if you did resect the internal sphincter with the anorectal malformations, that they were more incontinent. And we didn't, and we couldn't follow this. Why we saw some connection with the rectal inhibitory reflex. But what we found in the later study, and it's also just published this year, I think, or last year, is that in the same area of where is the rectal inhibitory reflex is, there is the anal sensation. And that we found, and that's very interesting, that the sensation doesn't come from lateral, but comes from the rectum. And if you did resect the last part of the fistula, you miss the internal sphincter and you miss the anal sensation. because the innovation comes from the rectum. And that's why we stand on our head in our center to keep as much as possible of the fistula. And we see if the fistula is kept in place, these patients function much better than the ones where the fistula was resected.
Yeah, I agree, Paul. I think that as much as possible, we try to maintain the last bit, because often you'll see, almost the dentate line that has been, tried to be formed. It is interesting in that you don't see that so clearly in, say, the rectoprostatic or the rectobladder neck. But interestingly, in those groups, you're trying to hold on to as much of that bowel tissue as possible. But yeah, I certainly agree that if if we can maintain as much of that remnant of the fistula as possible, then hopefully that will, we think, lead to greater sensation. I think as we know, even with our constipated cohort, that these children often just have no sense of when they are stooling. And even in my clinic yesterday, I had a constipation clinic, and sitting there, you can see the relief on parents' faces when you say that to them, that that their child, who they just assume is just pretending that they can't feel this or smell the contents in their nappy or pull up or their underpants, actually it's a very common thing for them to not be able to sense that.
I almost have to go, so I'd like to answer one of the questions which is below. Do you think that long use of stimulant laxatives can develop fibrosis? Well, there are long-term studies in adults which shows that you can have melanosis coli, which disappears if you stop using those laxatives. There's also a very nice paper from Sam Nurko's group showing that if you use stimulant laxatives for, let's say, 10 years, nothing happens. You can't get used to the medication. You can be weaned of the medication. So I'm in strong favor of using these laxatives if, for instance, polyethylene glycol in these patients doesn't work. And I've never seen fibrosis or histology papers showing that there's fibrosis in these children. And I'm very curious about the last question for you, Sebastian, because I was thinking it myself. If you see such a dilated colon, is it really true what you measure?
Yeah, thank you, and thank you to Taz for asking the question. I think that's Phil Dinning and I have gone backwards and forwards on this, Mark, about whether or not what you're actually seeing, with the manometry. Obviously, if you've got a large dilated colon, is the response that you're seeing to the meal or the bicicotal actually being appropriately analysed by the capacious colon. I don't think we're ever going to know that. We know that there are differences in outcomes depending on how dilated the colon is. To your question, Taz, certainly we've had a number of patients where we have done repeat manometry studies when they've been defunctioned for a period of time, and we have seen an improvement in the contractility. We've seen an improvement in the response to meal. We've seen an improvement in bicicotal. And is that an artificial thing because the colon has started to collapse back down again? Is it because you're not seeing the toxic effects of enterocolitis? We know that if you've got enterocolitis, that part of that is it's a chicken and egg. Are they enterocolytic because they're obstructed, or do they become dilated and dysfunctional because they've got enterocolitis? We don't know. I didn't highlight that work today, but one of my other PhD students in a basic science project is looking at the immunology of Hirschsprung's associated enterocolitis. We know that the immune cells and presentation of bacteria and content is different in Hirschsprung's than it is in anorectal malformations as it is in control patients. But I think that I have had one patient where we thought that they were going to be ready for closure of their ileostomy. We repeated their colonic manometry. There was no change 2-3 years after their defunctioning. So we made that decision with the family, who were very keen to have their son's ileostomy closed. by comparing these two studies together showing no change, they were like, no, we can't go back to what we had before with him being malnourished and in and out of hospital. So he's still got his ileostomy at the age of sort of 6.5, 7. So there's still so much to do and understand in this setting. It's really interesting.
Thank you so much. Thank you both very much. I think that was all of the questions. So I would like the attendees for being here. It was a bit longer than usual, but I think it was very interesting and very good that we still did this.
I'm sorry.
No worries, no worries. I think it was very good. It had been recorded, so I will be sending the link for the recording to everyone who registered for the webinar tomorrow via email. And please fill in the post-webinar survey for the attendees.
Thank you for listening and sleep well, Sebastian.
Yeah, thank you all very much.
Mark. And thank you, Hamida. Bye-bye.